Hi, everyone. My research uses pharmacometric models to personalize medicine for children. So my supervisor is already giving you expert overview of what these pharmacometric models. So when we down to the kindergarten level, what I learned in the last 10 months, what I understood from it. So as Joe has already completed, up to 95% of medicines used in children are not licensed. That means they are not studied or designed or formulated for children. The doses we use for children in upper of licensed medicines are based on adult data. However, children are not small adults. They monitor medicines very differently to adults because they're growing exponentially every day, and the way they handle medicines differs at each developmental stages. So the challenges we face with these licensed medicines in children actually summarizes very well what patient A's story. So this photo was taken when he's 3 years old, having bone marrow transplant. Because of his bone marrow transplant, we need to give him chemotherapy, and they will make him more susceptible to infections. And he does have infections caused by fungi. He's got a 48% of chances to die. So in order to prevent that, we give him azole antifungals to prevent or treat fungal infections. But these medicines are not licensed in children. So this do we share with them the story of what happened when he's having his transplant. He had a breakthrough fungal infection while on the antifungal. The medicines that we normally give to them when they have a bone marrow transplant affected his kidneys and liver while we're trying to find the right dose for him. I was worried. So the story actually outlines what challenges we have. It actually shows that we haven't got the right dose for him at the very first start. We have to keep on repeating taking blood levels from him and keep on trying and error before we find the right dose for him. Whilst we're waiting, it's actually having an inefficacy in medicine. It's actually having a fungal infection whilst already on something which is supposed to prevent an infection. Another disadvantage of not getting the right dose is toxicity. In this case, it's actually having effects on his organs. So it was lucky or fortunate that patient is survived his fungal infection and he's got a successful transplant. We can't 50 chance. So what we want to do is actually take the blood vessels we get from children, plug them into the pharmacometric model, which is a mathematical model, and actually using this model to help us to predict age-appropriate dose for these children. So pharmacometric modeling is actually a mathematical equations model to help us to describe the data. So we've got the data of the drugs we're interested in, that we measure from children to see how much they've got in the blood levels. And then using the models to fit to see if I can actually use a mathematical tool to statistically analyze them. What it also allows me to do is banking any other factors that may affect drug handling in children. For example, the gender, the medicines that they are having that may affect drug handling, but also maybe pharmacogenetic material and information that may come to light at a later stage. So what they actually help me to do is actually describe the data mathematically and help us to predict how they would behave under certain conditions. And then using this data to actually predict some or stimulate some doses that is age specific for them and right for them. So just let's take pharmacometric as an example. So it's an antiviral drug that specifically inhibits the single RNA viruses. It's licensed in adults in Japan for influenza, but using in aggressive industry for other RNA viruses and in immunocompromised children. There's no literature to describe how drug is handled in children. So we want to describe this and see how children actually metabolize the medicine. The doses we use for children are actually based on adult data. So we want to check whether we're actually giving the right dose for children. So the aim is to describe how the medicine is being handled in infants and young children using the pharmacometric models. We've recruited 8 patients that have received pharmacotherapy in the past at aging from 10 months to 11 years. The median weight is 15 kilos, and they received 200 milligrams or 400 milligrams 3 times a day. So this graph doesn't mean a lot to you, and I'm trying to learn and understand what it means. But what it actually shows is how well my model has been predicted and how good it is to match the actual patient levels we've taken. So the better you match the patient data, the better is my performance of my model and how I can utilize them, how reliable and the information I can gather from them. It's making a bit more sense because they've got data. So it describes how the medicine is being handled by the children. So we find that the clearance of the drug is quicker in children compared to adults. The distribution of the drug is different from adults as well, and the clearance is, the half-life actually shorter in adults, in pediatrics. And we can use this data and compare to the literature we found for adults. So we can actually compare and we actually see we actually need higher doses for these children in order to detect the viruses we want to treat. The next step of my project is actually use this model to simulate doses so that I can actually come up with a dose we can get it right first time. So in conclusion, pharmacometric models can help us to have age-stratified dosing, so I can reduce harm in mortality rates, increase dosing precision, and I can also standardize prescribing across hopefully the nation, not internationally, and also effective use of NHS resources and generate more evidence of using medicine in children. Thank you. Any questions? So your patient journey, you help to get the funding. Lots of different things happen to patients in the course, but how you test the veracity of the model with events that might be able to predict. And we're seeing that the problems that we have with the drugs, the failure to prevent the infection, was all of those big possibilities that very because what is the beauty of this pharmacometric is taking a population. So we've got different snapshots, smaller sample sizes from a lot of different patients. So you can actually analyze it as a population level. And what we can also predict is how one patient changes to the other. And I can also see any other factors, which I can also draw from the literature reviews that I do, or from my clinical experiences. And or, if it doesn't explain it, isolate other factors that may contribute to at least to the dosing they will try to simulate to achieve the certain levels. What's preventing it from achieving it? So you can actually give this information kind of compensating that way. Thank you very much.
Concludes our showcase. Thank you very much, everybody. It's been wonderful to hear about all the different work that's going on, all the wonderful AHPs and associated professions at ICH and wider UCL. This is, I guess, only the starting point of the networking collaboration with others. It's been really nice to meet a lot of you face to face. And yeah, let's get collaborating, get to know each other, all our collaborative opportunities in the future. Thank you very much.
Thank you.
Thank you.